Welcome to ATARC's 2022 Health IT Virtual Summit. For those of you who do not know me, my name is Alyssa Cole and I'm the event manager over here at ATARC, and I'll be emceeing today's summit. ATARC stands for the Advanced Technology Academic Research Center, and ATARC is a nonprofit that facilitates collaboration between government, industry, and academia in order to accelerate technology modernization initiatives. We provide ongoing opportunities for cross-agency collaboration through on-site interaction, learning, and market research. Thank you to our partners over at Pure Storage and BlackBerry for helping us to create today's summit, truly both great partners of ATARC. Additionally, I'd like to thank you for joining us today. We hope you have a great and informative day. We'd also like to remind you that after each panel, there'll be a time for Q&A, so please place all of the questions you have in those Q&A boxes at the bottom of your screens during those panels. Our amazing panelists will be able to answer them for you then. We also want to remind you that if you would like to be eligible for CP credits, that you do need to answer the poll questions that will pop up throughout those panels during the day. Up first, I would like to introduce our Visionnaire keynote, Torres. Gil is the director of the Artificial Intelligence within the U.S. Department of Veteran Affairs. Gil, please take it away.
Thank you, Alyssa, and it's great to be here. I see a number of familiar faces, which is always great. I'm the director of the National Artificial Intelligence Institute over at the Department of Veterans Affairs, and really excited to be here with you all today. So what I wanted to kind of talk to you about and essentially see people's get people thinking about is getting ready for the next frontier in health IT, which is going to be around human and AI interactions. So a lot of people, have talked about and have really, we've seen, in fact, there's an acronym for it, human-computer interactions, right? And that's really has focused a lot on kind of user interfaces and experience. And essentially it's been more of one-way interactions, almost like a command and control type of interactions, right? The human tells the computer what to do and gets a response. And the idea is often to kind of design the interfaces to make it more usable for the human so that they can more quickly essentially tell the computer what to do and be able to see the response specifically to what they asked for. What we're starting to see is really the beginning of more two-way interactions on a more equal playing field, essentially, right? More focused on kind of almost like a conversation, if you will, the sharing of ideas in a two-way peer-like communication type of approach. So AI may have its own ideas, it may share its own thoughts, and that can lead to essentially different types of experiences and interactions. And so that's what I wanted to come and tell you about today, and some of the things that we're thinking about as we look forward toward that new frontier, right? So toward that end, what we've been developing and piloting at the VA is this framework for ensuring trustworthy artificial intelligence. We've been developing it, working with, we've got a few White House Presidential Innovation Fellows that we've been working with, as well as our own staff. And it's good. It's going to be in line with the recent executive orders and recent White House guidelines. As part of that, it ensures essentially that we're working along these 9 principles for trustworthy AI that you can see in the executive order and some other recent guidelines. And so what to do that, we've developed these processes. We're also doing a few pilots, as I mentioned. So one is, for example, a trustworthy AI checklist. And so as part of that, what we do is we have a survey, essentially, where we go out to the field and we ask questions. And there are 3 different tracks. There's the kind of research and development under the institutional review board type of research and development, where they have certain sets of questions that we ask to see, how they're working within a trustworthy AI framework. There's the quality improvement track, and then there's the procurement and contracting track. And we've developed these survey questions and this way to get this feedback from the field that we're now working with. And it turns out a few other agencies actually expressed interest in that, and so we may see wider use of that. I want to take you to one specific pilot as well, and talk a little bit about that, which is where we have, and so the checklist that I sent, or that, not the check, but the surveys that I mentioned are ones that kind of go out to the field. They're looking at both existing projects, as people start thinking of new projects and so forth. But we also have an AI checklist that is essentially meant to be educational, voluntary, and one that you can have and look at and use as you're getting ready to start a project. So what we found is that it's often much easier to really essentially make changes to your project to make sure that there's no issues with bias and the right data is used and so forth at the beginning of the project rather than at the end when the model has already been built. And so to do that, we developed this checklist that people can think about as they're starting a project. And we're piloting it with different VA medical centers. And in one of our initial pilots, we actually found that an interesting result, that just having the list itself is educational, and the results in the decisions that were made in terms of which type of software to use, which approach to go in terms of the data, was different in the medical center that did have that compared to another one that did not. Now that was a very kind of initial pilot, but we're now looking to expand that to other centers as well to see if that kind of very preliminary result holds, and what kind of differences it leads to when people are using a list like that. So as we analyze the different use cases of AI across the VA, we're creating an inventory, and that inventory will actually be released in a couple of weeks. So for those who are interested, I know we get a lot of queries like, well, what are the AI projects at the VA? Well, we'll have that answer in about a couple of weeks when that gets posted as part of an executive order on Trustworthy AI. And it will be pointed to from it'll be available for people to see. Now, just to keep in mind, this is kind of an initial list that will keep being expanded as we receive more use cases, and this is our first year to release that, so it's a very initial list, and as we get to be made aware of more and interesting use cases of AI, we will be adding that to the list as well. So, that's kind of a piece of interaction that, we'd encourage, certainly if people are interested or they have other use cases, we'd love to explore that as well. One of the things that I also wanted to talk about is that we'll be having a way to engage with industry, academia, and government. Like, for example, a number of the people that may be on this call coming up in September. So September 7 to 9 is going to be the National Artificial Intelligence Institute AI Brain Summit. It's hard without a slide to show you, but brain has kind of the word AI in it, right? So it'll be kind of highlighted. Basically, the interactions between how the AI essentially is, in many of the current architectures, is emulating the brain, right? And AI can also be used to learn more about the brain itself. So kind of that two-way relationship and looking on that theme. And specifically, there are going to be three major areas looking at brain cancer, AI and brain cancer, AI and brain mental health, and AI and traumatic brain injury. And the conference itself, like I said, will be September 7 to 9. It'll be at the Hilton DCA Airport. and we'll be having a number of top-level speakers from across government, academia, and industry. So people interested in that, just feel free to email us at naii@va.gov. I'm sure you can probably find it online as well, but just wanted to bring that to your attention. And then the other area, which I think may be useful to go over in the last few minutes, is a new challenge that we just announced. And the deadline for that, there's still a few weeks, I think in August. It is it's posted on challenge.gov, and it is basically an AI tech sprint. We've had these before, very successful, and where we award cash prizes. Some of them end up, at least from the past, going on to getting contracts beyond the initial award. The award itself is essentially a gift, and it's basically a competition around a particular theme. In the past, we had a theme around veterans not currently engaged in the VA. Our current theme is around workforce development and developing and working on platforms that can evaluate the knowledge that people, let's say, within the VA may have that can, if they have the right kind of knowledge and or skills, you can potentially have them learn and work on artificial intelligence, even though they may not have come in with that training in the beginning. And as we think, as I mentioned, kind of that in the future, we're going to have more of this human AI interactions that are kind of two-way. It's going to be important to kind of educate our workforce in that area. And so that's why we announced that challenge on challenge.gov recently, and there'll be the deadline by August to apply for that sprint. It's a little over 2 months, and so it'll culminate, or we'll have kind of some very initial results around the time of the Brain Summit, but it'll continue afterwards, and then we'll be able to announce the prize winners and so forth. So with that, want to make sure that we have a great start to the conference and welcome you again. And thank everyone for coming. I think just kind of coming and is kind of the first step toward this conversation of human AI interactions, right? Learning about it, engaging with your peers, because what we found is that there are many definitions toward all these different aspects. Even what is AI, right? We've had a number of conversations on definitions. There have been a few definitions that have been published. For example, the National Defense Authorization Act has a few definitions. Essentially gets kind of updated each year. The executive order used, I believe it was the fiscal year 2019 version. And what you can see is AI kind of really, in that definition, really focuses on the both essentially the human type of thinking, the cognition type of aspects. It may not be thinking exactly like the human or in the same architecture, but it tries to simulate that in some way. Those kind of aspects are kind of focused on in that definition, which is quite interesting. Some of you may have seen also in the news recently a number of different platforms around AI where people are questioning whether or not it is, whether or not it has consciousness and so forth. Now, that's not what we're, our debate here today, but rather just the fact that there are questions like that coming up suggests that we are getting to the level where these interactions, where it's going to be closer to sort of peer level interactions, are possible, regardless of whether or not there's consciousness or what is actually beneath that, underneath the hood. There are kind of new possibilities that this is going to open up for health IT, where AI may have its own ideas that really come up and will engage the people who are talking with it. So with that, really want to welcome everyone and pass it over to Alyssa for the rest of the day, and thank ATARC for hosting this great event. I know they've always had a number of great events, and I always enjoyed them. So I think you're in for a real treat. Thanks, everyone.
Great. Thank you so much, Gil. That was a great keynote full of so much information. Up next, we're going to have our first panel of the day. For this panel, we're going to have Kirsten Padden moderate. So Kirsten, I'll turn it over to you.
Thank you, Alyssa. Before we begin, I just want to encourage the audience to please submit questions of your own in the Q&A section of this platform, and also remember to answer the poll questions as they come up throughout the discussion to ensure that you receive your CPE credit for today. Now, with that being said, I would like to welcome our panelists to go ahead and come on camera because we are going to begin with a round of introductions. So come on camera, come off mute, and please share with our audience a little bit about yourself, who you are, what agency you're with, what your role is there, and anything else you would like our audience to know about you up top. So I will go ahead and ask Michael if he could please kick us off.
Sure. Hi, everybody. I'm Mike Parrish. I'm the Chief Acquisition Officer for the Department of Veterans Affairs. And in my role, directly reporting to our secretary, I'm responsible for all 17,000 acquisition workforce members, as well as all facilities contracts and acquisitions related to the VA.
Thank you, Michael. Let's jump over to Heather next.
Hi, everyone. My name is Heather Damaris. I work for HHS's Health Resources and Services Administration in the Office for the Advancement of Telehealth.
Thank you. Chris, could you please introduce yourself next?
Good morning. Chris Nichols. I'm the Program Manager Director of Enterprise Intelligence and Data Solutions within the DIMS PEO that supports all of military healthcare, DHA Health Affairs. And yeah.
Thank you. Let's jump over to Quentin.
Hi, I'm Quentin Tyson. I work for CMS within the Centers for Clinical Standards and Quality over on the ISG group. I focus on strategic direction and thinking around the IT needs of the quality of care program within CMS.
Thank you. And then last but not least, our industry subject matter expert, Nick.
Hey, good morning, Kirsten. I'm Nick Saki. I'm with Pure Storage's Office of the Chief Technology. Office of the CTO. I'm the Principal Technologist for North American Public Sector, and very happy to be with you guys today.
Thank you all. All right, Heather, let's kick it off with you first, please. What does the Federal Health IT Strategic Plan mean for agencies? If you could please speak to your own experience.
Sure, absolutely, Kirsten. And thanks for having me be part of this conversation today. We realize, as was just discussed, there's a lot of definitions of AI. There's also a lot of definitions of health IT and telehealth. And so I represent, just like I said, the telehealth side of it. So when I look at the Federal Health IT Strategic Plan and what it means for agencies or telehealth across HHS, really looking to see how we can use the plan to assist telehealth and advancing healthcare, really so that our office, the Office for Advancement of Telehealth, can serve as a focal point across the full Department of Health and Human Services. And some of the activities, as you can imagine, we've worked on over the course of the pandemic have been heightened because we needed that continuity of care. But we certainly do have a core of work that we do, such as like funding grant opportunities to communities to implement telehealth, as well as telehealth research to kind of further what the evidence base is in telehealth versus in-person care, and now looking at the hybrid version of that and integrating telehealth into the regular standard of care and when that makes sense. We also fund technical assistance through regional telehealth resource centers. And we also have technology-based resource centers to provide TA to providers, as well as policy-based TA centers to provide assistance to providers, because it does vary by state if you're billing through Medicaid, which Quentin might talk about a little later from the CMS perspective, but certainly Medicare is standard across the country. So one of the things that came out of the pandemic and out of all of the struggles that we've had through the pandemic, the telehealth piece has been somewhat of a silver lining, if you will. And we were able to use some CARES Act funding to create a website called telehealth.hhs.gov. And I think this is one way to help speak to some of the pieces of the Health IT Strategic Plan when it focuses on telehealth specifically. We have one place that both patients and providers, and now we're building it out for researchers, they can go to receive sound information on how to get telehealth services if you're a patient, for providers, how to translate research into practice. We have best practice guides, we have billing information that we work closely with CMS on, as well as everything around the HIPAA waivers and changes so that it can be more flexible in the platform that they use during the public health emergency. So that website is www.telehealth.hhs.gov, just to put a little shameless plug in there. It really does have a lot of information, and we are building out the research side, as I think a lot of folks are interested on this site, to house all of the telehealth research that is coming out, funded by HHS or done internally, so that we can really understand sort of where the right fit is for telehealth, and depending on the situation and the cost effectiveness moving forward. So I'll end there. I know there's a lot more coming from our other panelists, but that's the telehealth perspective that I work on.
Yeah, that was great. Thank you, Heather. And that's a really good segue over to Quentin, since you brought up CMS. So Quentin, would love to hear from you about the same thing. What does the federal IT strategic plan mean for your agency? Quentin, you're muted.
My apologies. From the IT plan itself, for CMS, it means a lot. It really gives us that starting point and that vision and mission associated with the goals from the federal agency across the board. And part of it is really, it gives us the ability to also be innovative in how we meet those objectives, because I think part of the challenges that I've seen, from my perspective, is that there are so many sources of data. There are so many requirements and needs from data, because person A, the data scientist, may need a pocket of data for their objectives, and the next, the nurses and doctors may need their own types of sets of data. But I think what this does is gives us the ability to really focus on how do we actually consume the data, how do we actually analyze that data, and how do we report it out, because everybody does it differently. The actual vision, the plan itself gives us the ability to be innovative in how we actually acquire, do analytics and report it out, but also gives us a goal and mission for us to meet those needs as well. So especially working with some of our partners and other agencies across the board, because everybody does things differently. There's a lot of advancements or a lot of opportunities for interoperability that we continue to work towards, and dealing with standards similar to like FHIR. FHIR is one of the major standards that across the board that everybody's working towards, that we all can become efficient enough to work with and share the data as needed moving forward in the future.
Thank you, Quentin. And Chris, I would like to hear from you next.
So I would say, first and foremost, I think it is a great framework and a great starting point. What we're doing with it right now is really overlaying with all of our other strategies, right? And sorry, I was making sure it's not on mute. But the organization I manage, we have replatformed about actually 22 warehouses and 18 applications into what we call the MHS information platform in the last 3.5 years. And we've also moved it to AWS. And so a lot of things that we are focusing on and leveraging this capability, as many others, is really the foundational building blocks of where do we need to go. As Quentin was saying, data is everywhere. If you look at from an acquisition perspective, most people are focused on horizontal projects. Data is cross-cutting across everything. Data leads to information. Information leads to capabilities like machine learning, AI, and big data analysis, et cetera. But if we don't get the foundational building blocks correct, none of that matters to me. And so those are the things that we're focusing on right now, is cleansing our data, building all the right data dictionaries. When you collapse 22 warehouses together in 3.5 years, you have a lot of colliding data. We have systems that are bringing in 60, 70% of the same data this other system was bringing into different warehouses. And so part of it is getting that into a capability, and that parallel path at the same time that we're focusing on what does the future need to look like. Of the 4 core tenets of the plan, I do want to focus real quick on the security piece, because everyone first and foremost automatically goes to cyber. But there's also the security piece of who we're sharing health data with, how they're leveraging it, instead of them coming into our environments and doing the work they need to do. Because everybody wants information, everybody wants this data for different purposes, but no one understands the periodicity of the data, where the data has come from, where the data was input from, how high of a quality it is. And so when we share data out, if we're not careful, the insights from that information do not come out in the same way. And that's what we saw a lot during COVID work. I mean, we're sending our data daily to anonymized data to CDC. We're sending it up through the chains of military as well as DoD, and in partnership with the VA. But how we share that data, and that's why I tie that back to the security of that data. Part of it is understanding the historical aspect of where that data is coming from. And the other piece I want to highlight real quick, I think, is that encouraging the innovation. And part of that is we all work in very large organizations in the federal government, right? I think what we do poorly a lot of times, not purposely, but just we're focused on our day-to-day, is finding those pockets of innovation that are out there and leveraging those. And, I always joke that I want to steal someone's best idea, right? Because I don't want to have to redo it. And so across our 150 military treatment facilities and other places, we're always looking for where's someone doing something well. Because if they've already solved that answer, let's bring them into our environment. Let's have them build out the corporate solution instead of us paying additional funding to bring in another team to do that in the MIP, in the platform. So part of that is finding those pockets of innovation and then leveraging them. And then from the research side, fully accounting for how we're leveraging that information in the research environment and partnering to provide them the data they need. If it's de-identified, we have a project called the Virtual Data Environment that we're working on right now. Part of that is taking all the military health data and anonymizing it. And so then that way we can fully leverage it from research, because there are those appropriate gates in the research community like IRB and everything else that we have to get get human data. But if we can solve a lot of the questions our researchers are trying to accomplish, especially our GME, our residents and fellows that are out there in our facilities with anonymized data, then that would actually time to market, get them done with that work and move on to other things. They solve most of their answers with anonymized data. And so that's something that we're working on as well. And I think that all comes, like I said, this comes from the framework that is out here in the plan. And then how do we really leverage it and innovate together?
Thank you, Chris. And then Michael, I would love to hear from you over at the VA.
Of course, you get me just as the lawnmowers are going by, so hopefully you don't hear that. But so let me just highlight and build upon what Chris has said, because in the VA, the largest integrated healthcare system in the country. When I first took this role about a year ago, Congressman Bergman had a great point to us, saying that our biggest challenge in the VA is operating an analog bureaucracy in a digital world. And so we're undergoing a major transformation around not just our electronic health records, but also our financial efforts, and then now we're working on a supply chain modernization effort. And it all ties into the backbone being our data and being that integrated data. And I have a philosophy or doctrine that we're instituting across VA in the interest of jointness and transparency. So we're no longer working in siloed efforts, but it's called EII. It's that any new process we have in technology must be easy to use, integrated, and intelligent. So the easy to use concept is around human-centered design and making sure that our field users don't need to have an advanced degree to figure out what it is the solution that they're inheriting or receiving. Integrated is the system needs to be able to talk not only across VA, but part of that the federal health IT plan, strategic plan, is to be able to work across DoD in particular with our brothers and sisters over there. And then finally, it has to be intelligent. In the day of big data, it has to be able to provide us some predictive analytics, some visibility, some real-time awareness that we don't have today in the VA. And so we're trying to herd the cats and actually make that big effort to kind of fix the VA or modernize the VA. And inherent to what Chris had mentioned is our Achilles heel, candidly, is around the pre-processing and making sure that our data is actually properly cleansed and wrangled and put into an organized, universal type of way that it can talk to both legacy and current systems. But the future is bright from where we plan on going and where we want to go with technology and people and processes.
Well said, thank you. And then Nick, coming from industry, of course, is there anything that you would like to add to this discussion so far? Nick, I am having a hard time hearing you, but I don't. You're muted.
Okay.
There you go.
Yeah, we are very proud at Pure Storage to partner with literally every agency on this call. And we recognize primarily what we do is deliver data leverage in an uncomplicated, easy, accessible, and high performance way. Data is, it has become a cliche that it is the new oil, it is gold, et cetera. But truly, what is driving innovation at scale and driving the transformation of government healthcare at all levels is the access to integrated data sets that can be shared across patient providers, payers, researchers, et cetera, to give us a better understanding nationwide of the state of health, the efficiency and effectiveness of therapies, of treatments, of cures, which provides overall better quality patient care, better health outcomes for the nation, and the ability to respond to major, well, frankly, catastrophic events like COVID. So our responsibility as a technology provider is to deliver those data service infrastructure platforms that enable government agencies at all levels to derive the leverage from their data that gives the speed to insight with security, with simplicity, with all the things that Michael said, that Captain Damaris has said, that Chris Nichols stressed. These are all the drivers of 21st century governance, 21st century healthcare, and it's really going to revolve around how well can we leverage and protect the data that we're generating. And we're very proud to be at the forefront of those efforts.
Thank you, Nick. And I want to shift over to an audience question sent in by Gail Grosso next. Heather, this one is for you. Captain Maris, can you discuss any trends utilizing Telecare to better monitor high-risk populations like diabetes, where real-time data could prevent costly care and treat issues sooner rather than later, such as devices in the home that alert providers?
Absolutely. I'm so glad that question was asked. So when I mentioned we have grant making authority to fund communities, one of the really exciting things we did over the last 2 years was fund a direct consumer telehealth network grant. And if you're not familiar with the programs that we have within our office, this is really more of a hub and spoke model. We are able to address sort of like the need as years pass, and so previously we've done cohorts that focus on school-based healthcare, other cohorts that focus on emergency care. This cohort focusing on direct consumer care, remote patient monitoring, all of the technology that you're kind of talking about to reach these special populations, whether it be for chronic diseases like diabetes, or if the community or that region really has a big need for supporting children with special healthcare needs. You can take those grants. And so what we do as an office is take that evidence-based direct consumer telehealth network grant, and we gather a lot of data. It's data heavy from these grantees with patient level data, and we feed it into our research side. We fund 2 telehealth research centers, and one of those research centers then takes the data and publishes it after the cohort ends, and it's a 4-year program. So it does take a bit of time to get that information out, but we can see trends along the way. And we are monitoring across HHS, even aside from this pot of funds that we have for the direct consumer grant, what's occurring in real time. And there's so much data out there, as our whole panel is talking about, like trying to make sure we can mine that data in a way to inform whether the care that is being provided through telehealth and integrated into the standard in-person care that we've had is having better health outcomes, the same health outcomes, or less substantial health outcomes. And so that way we can really pinpoint where telehealth itself is going to help a patient. And certainly you're spot on with somebody with diabetes having remote patient monitoring. We've seen that before the pandemic. Now integrating some of the telehealth along with the in-person care that you get, so that in between visits or replacing a visit, you're able to get sort of the services that you need and monitoring real-time changes in your blood glucose or insulin levels. So that's just one example, but I'm really glad the question was asked, because this is what we have to monitor. And this is just one little piece, what we do in HHS. I'm so excited, as we work with the VA, because they're so advanced in what they're doing in telehealth, and DoD as well, that we partner across federal government as well. But But the key, and I'll just mention this because this could be a whole nother webinar, is making sure everybody does have access to data to reach high-speed internet, whether through broadband or satellite or through mobile service. That is the key if we want to try to improve access to telehealth services and analyze all these other pieces. So I'll end there. I hope that helped answer her question.
Thank you. And I also want to turn over to Chris Hare's question he sent in. This is for any of the panelists, so please come off mute or raise your hand if you'd like to respond. But he asks, how are the panelists exploring how to accelerate the processing of human readable data? So if any of our panelists could reply to that question that Chris sent in. Chris?
Trying to think exactly where he's going with the question. So how we say the question again? Sorry, let me make sure.
Of course. How are you exploring how to accelerate the processing of human readable data?
I'm going to take it different directions because I'm not sure exactly where he was going. From technical acceleration compared to, I mean, there's the technical aspect of accelerating access to data and that, well, and processing that data with multiple tools out there that we are exploring. I'm not going to name tools by name, but and then there's also it's also identifying all the different data sources that are necessary and needed. And I'll get to that in a second. But the example I was giving a second ago with our virtual data environment, to me, that's one way we're trying to get data to the users and then the consumers in a more timely manner by anonymizing it. And by anonymizing it, we're able to serve it up and not go through all of the requirements for human data from a research perspective and access perspective, because there's this is where it becomes a fine line of research versus operational use as well. And so where we don't cross those lines are the ability to provide that all of our data, a more portion of our data in an anonymized way. And then it's also about working through and identifying all the different data sources. As Heather was talking a second ago, I just started writing down a list. I mean, she was discussing telehealth and remote monitoring. We're working down the lane of a genomics capability right now to become the source of genomic data. And when you talk genomic data, it's not just genomic data for, there's the aspect of research with genomic data. There's the aspect of precision medicine with genomic data for direct data, it's like pharmacogenomics. And then there's also genomic aspects of things that we're doing genomic strand sampling around the world under our Armed Forces Health Surveillance folks. And so there's all these different ways, right? But then biosurveillance is a big piece of where we're building out the corporate biosurveillance capability for military healthcare in our platform. But then there's for us identifying the needs of operational medicine data, logistics data, purchase care data. We send out about half of our personnel go out, 50% or so, or a little bit more, go out to third party for their care based on TRICARE contracts. And so it's tying all of those data sources together that then gives us that holistic view of the patient, right? Because what goes inside the EMR is such a small, finite piece of the data that really is the holistic view in order to best and fully capably take care of our patient population and then partner with everyone on the phone.
Thank you. And Chris Hare did write a follow-up as an example. He meant by like processing health claims or other medical forms that are in text and handwriting into converting them to machine readable data.
Right. So there's some things that we're doing in that space, NLP and some other things on different projects in that space for sure.
Mm-hmm. Great. Any other panelists want to weigh in on that?
Well, this is Mike from the VA. I'll mention that, on the human readable side, which is more of the conversion back to a visualization of the, the technical codes. EGI Bill, for the example that Chris showed up there about the conversion of handwriting into, an automated system, where we've got efforts to do acceleration and intelligent processing of claims for exactly to that point here in the VA. And so we've started that, and it's really accelerated and reduced our backlog. And for those of us that are veterans that have gone through the old school pain of trying to get your claims done in months, it's now kind of compressed down to days and weeks, and more to follow on that as we continue to accelerate that effort.
Thank you. Quentin, I saw you came off mute for a second there. Did you want to reply?
Yeah, just a quick add on here. And so within at least my area of the clinical standards and quality, there is a lot of movement around machine learning and NLP. We leverage for different, well, we're trying to leverage for different reasons. One of them is basically, as Michael was stating, is that we receive a lot of feedback from the public around whether it is electronic, whether it is written on a notepad or written on a napkin and so forth. So we have to be able to ingest, finding ways to ingest that information, to be able to parse through that data to determine how the emotions are. Is this person, is a word in there angry? Is there a word in there they're being repetitive? So all those types of scenarios we're really trying to focus on so we can be more predictive in how we address our community, as well as trying to be less reactive in regards to how we do things as well. So we definitely have our hands in the cookie jar per se, but we're eating it a bite at a time.
Good point. All right, thank you guys so much. We're going to go ahead and pop up our first poll question here. Should be up on the screen momentarily. Poll question number 1, there you go. How familiar are you with the 2020-2025 Federal Health IT Strategic Plan published by the Office of the National Coordinator for Health Information Technology? So please go ahead and respond to that. And then I want to pivot back to my questions that we had prepared. So again, going along with the Federal Health IT Strategic Plan, if our panelists could share with us, we can just talk about this briefly, but some of the first steps needed to begin implementing this throughout the federal government. So first step, or most important step in getting everybody on board. I see our poll response came in. People are somewhat familiar, if not unfamiliar with it, but hopefully after this discussion they will be. So first steps for implementation throughout the federal government. Any panelist takers that want to step up and answer that first? Michael.
Sure. This is Mike again from the VA. So back on the concept of easy to use, intelligent, and integrated, and part of the key component of the strategic plan is around innovation and access. And so we have a mission in the VA to increase access and outcomes, because that's the piece that we haven't really talked about, is the outcomes for our veterans. And so that's our focus of our 9 million plus customers. And the first step that we've taken, just you may or may not know, and for your audience, is a system called pathfinder.va.gov, and it's the fusion of acquisition and innovation. And I'm sure you wonder why the acquisition guy's on here, because I'm a technologist, and I saw this from the outside when I was a CEO, trying to do things, to Chris's point about what we called in GE terms bleeding edge versus leading edge. And so we want to go from the very beginning, as I think Quentin mentioned, to be able to understand requirements, understand the data and the technology out there in the world. And I'll highlight that telehealth specifically, the VA has been the lead innovator for many things. I don't know if you knew that the first pacemaker was invented and made in the VA. The first telehealth appointment was actually done in the VA in 1967 for some of us old timers. So just a little history there. But on the innovation side, and this is an automated intelligence system website for people to come in and as vendors to on the sales side to show us, what they have to sell. It kind of goes around the Made in America concept about products and tools. But on the innovation side, it really helps us understand early at the very beginning of the acquisition lifecycle what technologies are out there in the world, and what are our industry partners developing, and if they need help in the incubation and the commercialization of a product, that we, through our innovation portal, and Gil's part of that, the R&D team that takes that section over, and intelligently we'll kind of work on that roadmap if it fits our strategic plan, that we have this new, whatever the new widget, new technology is. And if you all go to that site, you can see some of the things that we're interested in the VA from an innovative standpoint, but we want to partner with industry to grow and to accelerate our efforts. Part two, and I probably defer to another question or someone else to answer, but I'm pushing the concept that in federal government procurement, we are never the experts in technology, and this ties into the innovation. So I'm working on changing the game in the VA, where we don't over-engineer a commercial off-the-shelf system, but we give our industry partners, the requirements, the what we want, and let industry come back and translate our customer needs into into engineering specifications. And so this both Pathfinder and this concept of what I call statement of objectives is kind of taking root across all of government, and potentially that these become industry standards, and I'm sorry, government standards for us in the future. And nothing moves fast in government, so this is probably a multi-year long effort, but those are the first steps that I personally am involved with and taking across the enterprise with VA.
Thank you. Quentin?
Yeah, so from my perspective in regards to the steps need to be implemented, so from an overarching branch, I would think that there's need to be a continued touch point or community of practice used to create the plan to ensure it keeps moving. So the team that put the actual strategic plan together, it should be a continued movement forward. And along with that, there should be champions at each agency and office that supports this plan, and to be able to push the momentum within the agency, because a lot of times it could happen where the top of the chain knows what's going down, but if it's not pushed down to the actual worker bees, then it's not reinforced, it's not supported, it's not completed. So I think some of those two are definitely a key point, but also there should be some form of recurring checkpoints and analysis to determine if we need to shift left or right with the plan. Is each agency on point to meet those plans, and is there a timeline associated with that? And also, what does success look like? So with the strategic plan in place for each agency, how do they determine if they have met those goals or not? So I think those are some of the key pieces. And as Michael said, the biggest thing for it is innovation. So with the plan in place, it's identifying the goal. As long as each agency has the ability to innovate and how they reach that goal, that's going to bring a lot of ideas, a new way of thinking, and it may change the shifting of the plan itself left to right. But I think innovation is key, as many people on the panel has identified. And without innovation, then it's just a plan in place.
Absolutely. And Nick, would you like to respond as well?
I think what we see across the space is the need to develop infrastructure and technological capabilities that facilitate all of these different aspects of data leverage. We've talked at length about the interchange between agencies. Chris Nichols was mentioning having to share anonymized data with the CDC. Michael Parrish was talking about the acquisition mechanisms for adopting new technology and deploying it in a cost-efficient manner. And when you're talking about an agency that is as vastly distributed as the Veterans Administration, that's a heck of a challenge. Our focus is, how do we make data available? How do we make it secure? How do we provide it not only on premises, but also across the cloud, across disparate agencies? So these are really sort of, if you take a look at the OSI layer, these are like layer 3 considerations. It's data at the wholesale level. So how do we facilitate the subsequent utilization and application of that data further up the stack by agencies for specific applications, for specific research outcomes or specific financial outcomes? And then how do you do that at scale in a nation of 340 million people, all of whom are contributing data in one form or another, sometimes at the very fringy end of the network? As I live in central Wyoming, I don't have the benefits of gigabit broadband speed. So for telehealth applications, that's incredibly important. It's how are we efficient with moving the data physically and leveraging the data physically across all these platforms for all applications. These challenges, we're excited about the advent of 5G enabling us to get better reach with our data. And Chris, I wasn't forgetting all the ships at sea either, who have really skinny network pipes. These are huge challenges. This is actually what drives me as a technologist, is how do we get the most out of our data, and how do we get the most data? And we talked about data quality, data sanitization, data anonymization. These are all things that absolutely have to happen to ensure security and compliance with HIPAA and high tech. It's one of those fun parts about being government agencies, is that we have to abide by the regulations that we promulgate. But these are huge challenges for us, and I'm very encouraged hearing each one of these agency leaders talking about how they're addressing those challenges. But they're challenges for every one of our customers, and really everybody in the healthcare space across the country, and interestingly around the world. So these are going to be some of the core fundamental components of the data strategy that are driving how we're developing health IT technologies and deploying them in the field to deliver the outcomes that matter for our citizens and for our agencies.
Thank you, Nick. And Chris, I see you came off mute. Did you want to respond?
I do. I was going to say, Nick, I don't even know, but you blipped during your thing, and I was laughing because you were saying you're in the middle of Wyoming, and about 10 seconds later.
Yeah. You know, Starlink just launched another 47 satellites, so my bandwidth's getting better every day.
No, I was going to say, data project, I think is to make all of this successful, we have to remember one thing, that we're a healthcare organization. So our role is better health for our beneficiaries, number one, and also to be financially appropriate in order to manage these large organizations, right? And I say that because data projects really are change projects. They're not technical projects. And we need to always remember that, because I'm not a technologist, but I'm a critical care ER nurse by background. And so I'm always thinking about the workflow as well. And I mean, many years in hospitals doing clinical informatics, but we have to remember about that piece of it too, right? Because we can't treat IT and data as what is the impact on the organization and what we're doing, right? And I love the fact that, some of the questions that have been asked and everything else that people talked about are all of these great technologies that are out there. But we also need, we have to admit to ourselves organizationally, if we're not there, what we need to put in place to get there. Because we shouldn't go and acquire something if we're not ready to absolutely be able to support it. Does that make, and I say that because there's very few things that we do with data that doesn't have an impact to someone outside the data science, the data sphere, right? And so whatever we implement, we always have to be thinking and working with our chief medical officers, our CFOs, and all the right people in the organization who really are internal customers. And so I think it's just something we always have to think about, because in order for this framework to be successful, that's where we have to tie it in, because IT by itself does not live. We're there in a support role for the organization.
Thank you. Okay, we're going to pop up poll question number 2 here. It'll be on the screen shortly, so please remember to respond to that. It will say, in your opinion, there you go, how important is data to the 2020-2025 Federal Health IT Strategic Plan? And go ahead and respond to that. And then for my next question, Heather, I would like to kick it off with you. In what ways do you see the future of the Federal Health IT Strategic Plan being strengthened by using data?
Thanks so much, Kirsten. And just piggybacking off the last conversation, I think all that was said is extremely important. And then and it kind of ties into this question, really looking at the energy that we've had as federal employees partnering with private sector as well as state government to really figure out how to maintain continuity of care during the pandemic. That is what that passion drove us, because it was personal to us, right? Like we all had telehealth experiences, I would venture to guess, and it was really imperative to maintaining some continuity of care. And so as we look at the data, it might not feel as passionate to some people, right? But it's so incredibly important to look at what we're doing. And as Chris just said, for those of us who are clinicians, really understanding that this technology isn't just sitting in the clinic or in the hospital without it being incorporated into the workflow, because it won't be used. We're busy clinicians and we can't incorporate it unless we have some training and some time to go into the workflow and the process in order to incorporate it. And that's even aside from the data piece. So looking at, as I mentioned before, gathering and analyzing the data that we got before the pandemic, right? We saw some areas of telehealth and in the integration of EHRs working or not working, and letting that inform how we move forward. And then now looking at the pandemic, there are some holes in data, right? Like when we look at Medicare claims data, it didn't tag all of the visits, whether they were telehealth or in person. And so we're working through that, right? Like HHS is working on that data so that we have stronger data moving forward. And that way we really understand, as we can look across government data, whether it's that sliver of Medicare, the sliver of Medicaid, or whether it's all the private insurers out there that are analyzing their own data, to take that and really look at pre-pandemic, pandemic, and hopefully at some point soon, post-pandemic data, where we can really get a great picture of telehealth improving patient outcomes, being cost effective, and I'll say it as well, the fraud piece, making sure it's not opening the door to a lot of fraud, or making sure that it's not overwhelming an already burned out healthcare workforce, right? So we're in this healthcare sector. They've been overwhelmed. We need to make sure we do this in a way that helps the healthcare provider rather than cause additional burden on them. So all of those pieces, I think, are so incredibly important to use when we look at data to help shape what telehealth and sort of that integration of telehealth, EHR, AI, we have a whole bunch of different terminology here we're using, how that will look in a post-pandemic environment. And while I do pause on that technology piece, just digressing for 1 minute, on the website I mentioned, the telehealth.hhs.gov, that research side, there is a newly published research article, one of our research centers at the University of Arkansas published around the differences between digital health and e-health and m-health and telehealth, and you name it. Like, there's just terms all over the place because it makes sense for one sector, or maybe a certain program authorization within federal government, and why people are using those terminologies, so we can get a common set of language that really will help inform how we catalog the data too. So there's a whole bunch that we can work on here. And I think looking forward, strengthening our plan by using data and collaborating with each other to get some common metrics and terminology is going to be really important. And then following that data and tracking it closely to see what we can do in a post-pandemic healthcare environment, but definitely looking at improving health equity through increasing access to broadband or satellite or mobile services. That way they have the foundation of getting broadband services, if you will, for telehealth services, and then making sure that we're able to also improve health outcomes, make sure we limit fraud, waste, and abuse, and then look at cost effectiveness. Like, if we can get that out of the data and publish that in research, I mean, we're going to be in a really good place to let providers know, let patients know this is going to be helpful. And I didn't even talk about insurers, but they're really interested for other reasons as well. So this is all very, I think, important for us to be talking about. So it's exciting to have this panel of energized, passionate people around the health IT world to talk about it further.
Yeah, absolutely. And is there any other panelists that would like to weigh in on that as well? And I'm happy to repeat the question if you'd like, Quentin.
Yeah, sure. And so from my perspective, well, data is data, and we have a lot of data. As mentioned earlier, I'm sure it's Michael or Chris, basically data is a new oil. And one of the challenges that we see across all federal agencies, even private sector, is that there's duplicate of data. You can have the same type of data in 10 different areas. And part of the challenge is that when you do that, it becomes a security risk because, one, some data may be local, whether it is across the US or at somebody's desktop. So part of the challenges that we've been faced with is trying to come up with a centralized data repository that meets the needs of the entire agency, which, of course, as you know, is very difficult because everyone needs the data for different reasons. And so as we start to really pull together all the different components and within the agency, it's just understanding what are the needs. How do we actually create a true CDR where we have an interoperability function that allows everyone to leverage the same data? We reduce costs overall because now we don't have 10 copies of data in different places. We reduce security because we only have to focus on securing the actual CDR, but also we give our community the ability to leverage different tools to access that data. Part of the challenge is that there's a lot of tools across the world that allows you to do analytics. One of the challenges that when we identify you can only use tool A or tool B, then that becomes a challenge because that tool doesn't do what everybody needs it to do. It may meet one person's need, but not the next. So a lot of it is really just trying to sit back and really identify what are the true needs of it and how do we approach it. And another challenge is real-time data updates. A lot of times we're pulling data from other partners that it is 2 days, 3 days, or a month behind. So it makes it harder for us to do real reports for our consumers. And one of the things we want to be able to do is give our beneficiaries the ability to see real-time data. If it takes 5 weeks for us to transfer data between one organization to another, then we're 5 weeks behind. If there's a specialist that needs to be seen, you have to wait or carry the paperwork manually. So we're really trying to figure out different ways how we approach making data readily available, making it accurate, and making it more efficient for the beneficiaries to leverage.
Thank you, Quentin. Okay, we are going to pop up our third and final poll question, and then we're going to try to answer as many audience questions as we'll have time for, but this is our last call for audience questions. So third and final poll up on the screen here shortly. Is your agency working on implementing the federal health IT strategic plan? Please answer yes or no. Okay, that being said, panelists, again, please turn your attention over to our audience Q&A. We have a few that just recently came through. So we will start with a question from Layla Syed Hollister. She asks, for the group, in terms of leveraging data to improve health equity, what are your agencies doing to identify inherent and or implicit bias using ML or AI, for example? And you can just come off mute whenever you are ready to respond. Nick, it looks like you're off mute. Would you like to respond to that? Or maybe
Sort of outside my realm of expertise, but I'll take a crack at it.
Sure.
And I spent a lot of time looking at the third and fourth priorities of the data strategy, particularly around and pertaining to questions that were asked. Improving the harmonization of data elements, driving application interoperability, securing the data. Those are all the things that we focus on primarily at Pure Storage. Bolstering secure access to large data sets. I mean, we touched on cybersecurity as a component of this, but obviously, when you start talking application level at the front end and really even in the middleware layers of the architecture, this gets a little bit nerdy, I apologize. You have to have an end-to-end consistent and coherent security framework that protects your data frameworks. So this is something that I think the federal government has done a tremendous job of implementing. Certainly within the federal government, and we've seen that extend out to the retail end of the application chain over the past couple of years as well. But there's always going to be more risk the further away or the broader your attack surface becomes. So the more people are using or accessing in a given system or sets of data, the greater the possibility of misuse or compromise. So, from my perspective, we've got to guarantee or do our best to provide assured access to appropriate users for appropriate use of the data. But this is always going to be a tremendous challenge for any organization. And there is not a great answer to it. We can forensically analyze who accessed data. We can forensically analyze what happened to it. But being proactive about it is going to require a very, very holistic approach. Leveraging artificial intelligence and machine learning for security and for handling of that data, simply because of the scale and speed with which cyber threats can occur these days. Those are just a lot of things that keep me up at night, frankly, as I work with a lot of agencies to figure out, how do we do this? How do we create internet scale information capability and data leverage, but also provide the security and protection that we're required to via statute, by regulation, and even by ethics. So I wish I had the pat answer, but honestly, there isn't one, and it's going to evolve over time as well. It's as soon as you have a new cure, you get a new threat, and that's just the nature of cyber reality. So thanks.
Yeah, thank you, Nick, for your response. And Quentin, did you want to reply to that as well?
So I'm not as versed in this, but I will take a quick stab at it. So basically, I know within CMS, there are different offices that focuses on equity across the board, specifically like our OMH, our Office of Minority Health. They really focus on accessing the data, or getting the data they need to make informed decisions to determine if the actual quality of care across the globe, across the US, is actually in sync with what we're supposed to. So basically, a lot of times what we do with data, of course, we get the data, we analyze it, and we make the informed decisions from it. So there are steps being taken to really look at that. But as far as the details associated with that, I can't speak to that at this time without referring to or tapping someone else on the shoulder to get the information. But we are leveraging AI and ML to really focus on trying to gather that data and make informed decisions from it and be proactive about it.
Thank you. Chris?
I was just going to say, I mean, health equity is critical in this country. And without us figuring out that piece, and data will help drive that. This is me just speaking as Chris Nichols, because we are not really addressing that directly within military healthcare directly. And from at least in my space, but it is critical that we do as a nation, because that's going to also help lower our costs overall in the healthcare space. And so I think there's a lot of opportunity there.
Thank you, Chris. And our next question from James Kovach. Hi, James. Applications are the vehicles that power the objectives of the federal health IT plan. So the question is, how are the panelists thinking about securing and protecting those mission critical applications in order to further implement the federal health IT plan? So any insights from the panelists are welcomed. Chris, did you just come off mute?
Yeah, I mean, Nick really said it already. The answer to that is the cybersecurity aspect of everything that we're talking about. There's cyber, and then there's infrastructure support, right? Those are there's a lot more there, but just break it down to those two. We have to do everything in order from a cyber perspective. And I have an amazing cyber team that is extremely proactive in the way they're approaching everything. We moved quickly in 17 weeks from being on-prem right at the beginning of COVID into our cloud environment. I don't know if we could have done it in 17 and a half weeks, number one, had it not been because of COVID, because no one else had anything to do, because everyone was locked in. And so this became the cycle, right? But more importantly, through that experience, we have put cyber at the leading and bleeding edge. And the team is always looking at how do we do things? How do we go out? How do we do green team, red team assessments, not just waiting for a new ATO, but being proactive in our cyber posture. And if we don't do that, and we all don't do that, we're always going to be in it. It's, as Nick said, it's always going to change. Every day, something new. And so I think that's what excites that team. And I think that's what excites that workforce. But it is critical.
Thank you, Chris. Go ahead, Quentin.
Yeah, and so really to piggyback on what Chris and Nick said, we try to include security in everything we do, especially from our development perspective. So within our CI/CD pipeline, security is always moved to the left. In every stage of our life cycle, security is inclusive of that, because again, we have to test it before we put it out for use in the production world. And cybersecurity, we have our cybersecurity teams that work within CMS and other external components, but it's never going to go away. We all have to be mindful and protective of our data. Again, the data is a critical piece for everyone. So if it's not secured, then there's no reason to have it, and we can't support our beneficiaries. So we are definitely focused on that each day that we do our job.
Thank you, Quentin. Okay, and then the next question, back to you, Mr. Nichols. Scott Campbell asks, have you started efforts in EIDS MIP to connect these immense data and AI ML predictive models closer to the decision makers and users to optimize outcomes such as readiness, DHA operations, R&D, precision medicine?
The short answer is I know we only have a few minutes. And I know, Scott, I could answer this for 2 hours, honestly. The answer is yes. As we've matured, and it goes back to some of those building blocks we talked about, and it goes back to something Quentin said, and I wrote it down because it was about cookies. But the cookie jar, it's one bite at a time issue, and us doing these things, there's in this space, there's more work than we're ever going to accomplish, right? And so part of this is continuous prioritization. And when I say continuous, I mean weekly changes on what our priorities are from a project perspective, just because, things occur. And so part of it is building that underlying infrastructure to support all the things that you had just asked about, right? And so it's doing that, and also really focusing on the fact that, some of the things that Quentin was talking about that he's addressing, they're addressing at CMS, going back to what I said, these are change projects. And a lot of these are not technology problems. They're people and process and policy changes, and pushing people from the old way of doing business into the new way. The value that we've seen, and I think the VA is seeing this as well, and we've used this as a catalyst, as we're deploying MHS Genesis, our new EHR, we're leveraging that because it is a forceful change that people have done certain things a certain way for 25 years, from paper to our old legacy EHRs. But now, as we standardize and we drive that standardization around the processes, this is in the data space the same way we're approaching this. And I think that's really helping us move these things forward. So yes, we are addressing all of those things and putting them at the edge, or bringing them to the consumers in a more timely manner. But it's getting people away from saying data has to be perfect, so it's 90 days old before it's perfect. If you look at CLABSI data, which is central line data, if we wait for things to be perfect in the data, then it's too late to be reactive on them. And so it's also then changing that mindset, being comfortable with the data that's being presented to you today and saying you have a 70% confidence in that at 90 days, at 90% at 30 days, and 100% at 90 days. But it's just that mindset change.
Thank you, Chris. And in the interest of time, we're going to stop our Q&A there, but I will take those questions sent in and ask if our panelists would like to provide an email response, and then we can get you those answers later on. But that being said, I want to give each of our panelists the opportunity to share their closing thoughts with our audience. What is a key leadership takeaway that you've gotten from this conversation that you would like to end with? So we'll just go around and hear from each of you on that. So let's start with Michael, please.
Well, I guess my big takeaway is, VA specific, and also in these discussions we talked about, is in all our transformations government-wide and all our improving access and outcomes and jointness and integration, that as I mentioned earlier, the key, the long pole in the tent, as we say in military terms, but the key component is data. And it's critical that our data strategies be developed, be robust, and exactly some of the questions are made, be secure, because in reality, we're in asymmetric war right now, around the world. So, the data is the linchpin for everything that we do. In my professional term of art, I usually say crap in equals crap out. So if our data is not correct, doesn't matter how great of a technology widget or system you have, it's not going to work. And that's part of the qualitative and quantitative aspect of what we're pushing in the VA and around government. So
Thank you, Michael. All right, Heather, let's hear from you next.
Sure. I think, this conversation just really reminds me who our audience is and what we're doing to fix problems and collect data to help identify areas of need, and really working towards that through the federal health IT strategic plan. There's a lot of stuff that can be done just to be done, data that to be gathered just to gather. And I think keeping in mind where the need is from whether it's the beneficiaries or the providers, and even the researchers and the data they need in order to publish, well-rounded studies that really look broadly at the issue. I think those are all important things for us to keep in mind. So this is a great conversation that kind of triggered a few things for me to recall. And so as a leader, I think we always have to keep that at the forefront of our strategic initiatives.
Excellent. Quentin, let's hear from you next.
Great. Really, I think the panel has really said it all. Data is the key. And the important piece of it is making data useful to our consumers, whether it's beneficiaries or our providers or nursing homes, home health care, whatever the case may be, making it useful, because having a large subset of data and people not understanding it, it's not going to be beneficial to anyone, especially from the endpoint of trying to make the beneficiaries have more accessibility to it. but a lot of times we have to ensure that they understand what that data is and how to use it. So a big piece of it too would be more of the user experience and HCD involved, associated with onboarding them and having them understand and feel comfortable with the data they're now receiving. So it's important for us to get the data to them, but also that they can actually understand the data.
Absolutely. Thank you. And then Chris, let's hear from you next.
I think I've said it multiple times. Data projects are change projects. They're not technical projects. And I think we all have to remember that. And ultimately, I think everyone has said it, but what really matters is, focusing on patient-centered care and the patient and the clinicians and the impacts on their healthcare and the efficiency of the organization to support that. Thank you.
Excellent. And Nick, we will end with you. Nick, you are muted.
Thank you. So I said it before, and I just want to reiterate it, and it's been said by this group as well. We're talking about health IT strategy broadly, but all the conversations are revolving around data, which is the whole reason why we do IT to begin with, is what can we know? How quickly can we know it? How do we protect it? And from our perspective at Pure Storage, we've been very proud to partner with the largest EHR systems, the most advanced research institutions, the largest hospital systems and public health institutions, and agencies at all levels of government over the past 10 years, because what we do fundamentally is not storage. It's actually data service. The leveraging of that data to uncomplicates leveraging that data. You don't have to wrestle your IT infrastructure into submission. It should work for you. That's one of the hardest challenges at the Chris hit on it in his first segment. It's got to be EII. It has to be intuitive. It has to be intelligent. It has to be efficient. These are, from our perspective in industry, we have to deliver these capabilities so that we're not thinking about how do we make the infrastructure do what we want it to do. We focus on what are the outcomes that we want to get from our data and how quickly and efficiently can we deliver that. That is our sole focus, and from where I sit at Pure Storage. It's really transforming the understanding of what the IT infrastructure does to deliver the outcomes that matter. And that will continue to be our core focus going forward. And we continue to be really proud to partner with agencies to figure out how to get them there. How do we deliver the capabilities that make that possible? So I want to thank everybody in the audience, especially for your time and attention today. And I want to thank all of the panelists for the tremendous insights and really the candid discussion about what are the challenges ahead of you. And thank you for letting us participate with you.
Absolutely. Well said. Thank you all so much. And with that, I'm going to turn it back over to our MC, Alyssa.
Great. Thank you guys so much. That was such a great discussion. Up next, we're going to have our second panel of the day. For this panel, we're going to have Jory Heckman moderate it. So Jory, I'll turn it over to you.
Thanks, Alyssa. And thanks everyone for tuning in for this panel for sorry, I had to start my video there. Thanks everyone for joining me here. And we have a great conversation lined up here. But I do keep in mind, please keep your questions coming in throughout the conversation. We want to make sure we have time for those throughout the discussion. And of course, please keep those poll questions responding to those as we go through the conversation here. Without any further ado, I will introduce our fantastic lineup of panelists here. We have Lauren Alexanderson, the Health Portfolio Lead at the VA's Office of the CTO. We have Scott McKeithen, the Warfighter Health Mission Manager for the Chief Digital and Artificial Intelligence Office at the Defense Department. We have the Chief Transformation Officer for the Centers for Medicare and Medicaid Services. And we have John McClurg, the Senior Vice President and CISO at BlackBerry. Everyone, thank you for taking the time here. But I will just start the conversation out with an opportunity for everyone to introduce themselves a little more fully. But in doing so, just tell me a little bit more about one of your biggest mission delivery challenges since the start of the COVID-19 pandemic. Lauren, I'll have you take the first crack at that.
Good morning, everyone. As Jory said, my name is Lauren Alexanderson. I work in the office of the CTO at the VA, and my focus is on healthcare, which of course is incredibly relevant during the pandemic. VA is one of those organizations that was really leaning out ahead prior to the pandemic and had invested in quite a bit in enabling veterans to get care from home. But to say that it was not a challenge when we really were forced to pivot to providing 100% care and providing as much care as possible in a telehealth environment, it was certainly a challenge, and we wanted to make sure that our systems could support the sort of massive scale up that we were doing, but also that we were continuing to make sure that we were reaching our veterans with plain language, clear content, and really useful information. Our office is very focused on human-centered design. We really focus on the veteran user as well as our clinician partner users and the staff who need to facilitate that veteran healthcare. Back over to you, Jory.
All right, great. Thanks for that, Lauren. And Scott, we'll turn it on over to you.
Absolutely. Thanks, Jory. So from a CDAO enterprise perspective, CDAO is relatively new. Historically, though, I was part of the JAKE as the Warfighter Health Mission Manager. And the challenges was, we turned in the last session, it was data access. It was the ability to look across the multitude of different platforms and collaborate together and be able to get down to the county, the state, and even the zip code level from data. It was bringing in data sources that we historically had not looked at together. That was the logistical data, that was bed count data, that was the overarching, how do we address this pandemic? Even though we had a plan in place, the amount of data and the sources of data was not brought together in a common platform for visibility and to be able to answer the whole of government approach. Over.
All right, and Doug, over to you.
Everyone, it's nice to be here today. I'm also a primary care doctor and chief transformation officer in the Center for Medicare. And so Medicare, I think as folks might know, it covers more than 63 million Americans and represents more than 1 in 5 healthcare dollars that is spent. And so during the pandemic, there's been so many challenges I think that CMS has had to face really head on. Maybe I'll just highlight one. People's behavioral health conditions have really gotten exacerbated by the pandemic, and the prevalence of behavioral health conditions has really increased. And I think as my colleagues at the VA and DoD know in particular as well. And so the one thing that we've really been trying to focus on is how do we really make sure the behavioral health workforce is working for folks and we're paying for the kinds of services that people really need and deserve to match the need of this pandemic. So there's so much more that we can talk about too, and I'm sure we'll get into.
Okay, yeah, plenty to dive into there. And John, to give us an industry perspective on things, just give us a more zoomed out perspective on things. How have you seen agencies rise to the challenge of the pandemic, and what lies ahead?
Thank you, Jory. I am the Senior Vice President and CISO at BlackBerry. And in that role, I came to that through a 10-year career in government, the 3-letter agencies, and 25 years in various large corporations, where we've been grappling for some time with the classic challenge of the growing attack vectors that we have in the community. The porosity between work and home has only increased with the pandemic. And with that increased platform, we've seen the adversaries out there just salivating because of the new expanded opportunities they have to strike. In fact, we saw our remote workers now becoming almost the equivalent of what we know we face in the way of challenge when we're extending telehealth to the telehealth user, and our employees during the COVID period are almost the equivalent in terms of what we needed to ask in terms of their ability to access data, to do that in a secure manner and in a way that could thwart the activities of an adversary that was just growing ever more sophisticated with the use of AI, machine learning, morphing their attacks almost instantaneously, so that keeping each and every one of these participants in this expanding connected world has been the challenge. We know that old saying, I think Kennedy advanced, that rising tide lifts all boats. That's if everybody's in a boat. A lot of these tele users or these extended employees aren't even in a boat. They're holding on to piece of driftwood it and don't have the mechanisms and means around which to secure their data. So addressed by the strength and power of AI machine learnings that have a small footprint, don't require a lot of infrastructure to go out and keep updated, but it's an exciting world. And I think there's good reason to be hopeful. A lot of people are coming out of the pandemic with sort of a despondent sort of a sense of the effect, the challenges of that, but there's really good reasons to be very hopeful in what we're going to be able to achieve. Jory, back to you.
Thanks for that, John. And I'll keep going with a trend that, or a topic that has been much discussed throughout the entirety of this day, which is just telework and or telehealth rather, and the opportunities around that. And I think most of you can really speak to that. Lauren, certainly from the VA perspective on things, just tell me how VA scaled up to deliver on telehealth and what all went into making that possible.
Sure. So as I mentioned, VA has leaned out pretty far ahead of providing telehealth. We recognize that veterans live in sometimes really rural environments. And so sometimes that's the best way that we can reach them. Our Office of Connected Care has different types of programs for providing telehealth. So there's what you think of traditionally of I get on the computer at home and I'm connecting to a doctor who may be in an office. But they also have modalities where veterans may come into one facility and be able to talk to a doctor in another facility, to be able to connect specialists across the sort of nation, which enables us to sort of make the best use of having a national healthcare system in some ways, and connect veterans to specialists and providers in different places, no matter where they are. I think VA saw somewhere between, depending on what time you look at it and what pin you drop, somewhere between a 300% and 1,000% increase in our use of telehealth during the pandemic, which was required us to certainly, look at the different tools and technologies that we were using and make sure that those were able to meet the needs and meet the sort of velocity and speed that we were trying to provide. But we also were recognizing that about 15% of veterans don't actually have an internet connection at home. And so VA also has a digital divide program, which can help veterans get connected with, they can get a loaner iPad or get support being able to connect to the internet or get a smartphone or something like that. And I think that was a really critical program for helping us kind of reach those veterans who may not have been able to benefit from telehealth at VA. Now that I won't say that we're post-pandemic, as I think folks on the previous panel alluded to, we now have another variant, BA.5, which is we're already seeing spikes in hospitalizations, and we're seeing sort of we're going to see challenges like this for, I think, a while, but we are continuing to lean in. We are continuing to recognize that veterans want to be able to get care close to home and still benefit from the care that they receive at VA, whether that's from community care or directly from VA providers.
Okay, thanks for that, Lauren. And Scott, on the DoD side of things, in terms of the military health service, have they risen to the moment and delivered on telehealth? And how have you and the CDAO helped support that?
Yeah, I definitely do. It forced a mechanism to create the appointment type for virtual health that did not previously exist. It forced logistically to push out the IT infrastructure to the respective MTFs to be able to host these. And exacerbated the use of the national military, the virtual health center out of San Diego. It pushed the 5G aspect and the work being done at the 59th Medical Wing in San Antonio. So from a DHA perspective, yes, the COVID pushed us to work in a faster way than we historically have before. From a CDO perspective, though, ours has been more of identifying the platforms and then being able to support the virtual environments with the hosted data and information that they needed. Over.
Okay, thanks for that. And Doug, over on the CMS side, I know certainly that's at least a supporting role for the larger healthcare community as they were dealing with telehealth. Can you tell us a bit more about that perspective on things?
Yeah, absolutely. And I'm going to echo also some of my colleagues. I mean, we've really seen telehealth rates go through the roof in the healthcare system writ large. And so we've really been trying to support that based on like the way that we pay for care. And so much of that has been, how can we make things available via telehealth that would otherwise need to be in person? And the people that Medicare covers, people with disabilities, older adults, a lot of the people are the very highest risk for COVID-19 as well. So it's been particularly important that people can access care in their homes or somewhere else that doesn't necessarily provide a infectious risk. And so some of what we've done in, for example, the behavioral health space is we've now seen enough evidence, and Congress has passed a law saying that we have the statutory authority to do so, to expand telebehavioral health permanently, even after the public health emergency has ended. And one of the considerations here is also, Lauren had mentioned the digital divide. And so this is something that we take into consideration when we're trying to figure out how to implement these laws. What we've seen also is that, not everybody has access to the audiovisual technologies and audio-only technologies. Just calling someone on their phone might be the best way to access people when the digital divide is coming up. And, I've seen this also firsthand because I'm a provider that has also provided telehealth services. And oftentimes I might have an appointment on my schedule and that person, is not showing up. I'm like, oh, they might not have really gotten the platform right. So I give them a call on their phone and we just do the visit via their phone. And so I've also seen firsthand how important that can be for so many of the people that we serve. And it's something that we'll continue to explore about how we can continue to navigate the waters of the pandemic, which is, unfortunately, as was mentioned, is not over.
All right, great. Thanks for that, Doug. And John, to get your perspective on things, how do you see the not just the opportunities around telehealth, but what do you consider some of the challenges in getting there?
Well, and again, Lauren gave me a segue there when she mentioned the digital divide. You think of the challenge we have with those who live in the digital divide and the concept of the core IT elements, but do you add on to that, well, what about the security dimension? I mean, you're just talking another level of confusion and ignorance in terms of what those might be. Even those who enjoy a robust and rich understanding of the technology and stuff are still often found guilty in terms of how they apply and they think of the security aspects of this. We need to remember that in the midst of the COVID, the bad guys are out there, and the FBI provided us data to say that, in fact, we've seen spear phishing attacks and a social engineering sophistication just soar through the ceiling in terms of the adversaries' understanding of how to manipulate a person who's maybe a victim of that digital divide, or even those who aren't, to social engineer them in a way that exploits the sort of questions and the aspects of telehealth that affords them an opportunity, because they know, and I think the last data I saw down in the dark web is that stolen healthcare credentials still command the highest price of any other stolen credentials, second only to, get this, gaming credentials. That still commands that kind of price out there. So with that kind of motivation by our adversaries, they're going to look for every opportunity in an ever more connected world for those opportunities to strike through it. We call it the Internet of Things. And I used to say, well, and I like to call it the Internet of Everything, because we knew Hodgkin's patients were connecting themselves to the internet. But now with telehealth, it's not just Hodgkin's patients, it's potentially all of us are connecting ourselves into the internet. And so it's what I call the Internet of Everything. And again, with that growth of that, there's these opportunities for these robust adversaries to exploit the pace and speed at which they can leverage tools that are provided to them in the dark web, like ransomware as a service, the ability to morph and alter their attack vectors, and almost for each and every potential victim. That kind of sophistication and speed just is what's requiring that we as institutions step up and leverage the strength that is now available in these math models that we've developed, that are AI supported math models that can learn and predict proactively, instead of being stymied in this world of reactive detection where most of my career has been spent. We now, as healthcare providers and as security professionals, have that opportunity to step into the world of proactive predictive prevention. Boy, I like the P words, right? Proactively predictive prevention that means pre-execution before one of these poor persons who's going to have his first experience with the internet in a telehealth session, before he has an opportunity, or maybe he does click on something he shouldn't because he has no notion of what not to click on. He does that without the repercussions of what would historically cascade down upon him in the old world before we had the strength of these new math models.
All right, thanks for that, John. And I think it's probably time for our first poll question of the session. Alyssa, if you could get that ready for everyone. In your opinion, how important is customer experience to telehealth? And just a heads up for all the panelists, we'll pivot the conversation to customer experience. So we'll keep an eye on the results here. But if they say not important, maybe we'll just move on. I don't know. That would be not a good endorsement of this. Okay, very good and very important. 97%. That's what we all like to see here. So yeah, I will keep on that thread here because, of course, the telehealth picture here really does have an intersection with customer experience. Doug, we'll start with you here. How do you see telehealth being a vector here when it comes to improved customer experience?
Yeah, absolutely. Thank you. And I mentioned, I guess, some of what I've seen firsthand when I'm delivering telehealth and how sometimes the customer experience doesn't go exactly as planned. It can be really important on the receiving end of the provider to try and navigate those waters. But also, I think in general, from a Medicare perspective, where we're really trying to think about this, we're really trying to improve patient experience across the board. And so one of the main ways that we do that through Medicare is through our quality programs. And we also have the largest patient experience survey in the country, in the CAP survey. Folks might have heard of that. And so this is run really in partnership with ATARC, the Agency for Healthcare Research and Quality. And this survey really gets included in a lot of the value-based care programs. So as Medicare is looking to move the system towards paying for fee-for-service, so like paying docs to do more and more things, really paying for value, making sure that quality of care is included in that. And so where telehealth really fits into this, it's within this larger ecosystem of really trying to move our healthcare system towards value. So insofar as providers can use telehealth technologies that really do improve customer experience, they should actually be getting rewarded for that on their quality ratings. And the same thing happens on the Medicare Advantage side, where we're working to really ensure that patient experience is a part of the star ratings that Medicare Advantage plans are measured against. And so in all those ways, we're trying to move our system in that direction, but we also, of course, rely on a lot of the technology companies that are developing these softwares to make sure that the customer experience is top notch. And then, then the providers, when they're looking to see, okay, what kind of services do we want to adopt, really should be taking that into consideration.
Okay, great. And Lauren, I know over at VA, customer experience is a major concern and something that they spend a lot of time focused on. And you had mentioned the digital divide side of things here. So between all of those things, again, how can telehealth be a seamless service that the VA provides?
I want to start by saying I'm so glad that we're kind of in the point of like healthcare at this point, where we can ask a question: how important is user experience or patient experience to any service in healthcare? And the response is 97% very important. Like, that's such a shift and such an important shift. And I'm so my heart is warmed by seeing that. I think patient experience, whether you're looking at telehealth or whether you're looking at in-person health, whether you're looking at the bridge between those, between kind of digital going in person, going back to digital, and kind of what that looks like, it's critically important. And it's also important to consider the clinical experience. I think we have pivoted toward focusing a lot on the veteran experience, on the patient experience. I've heard a lot of different panels and discussions and read articles on that recently about how do we make sure that we're meeting our patients, our veterans where they are, how are we providing them a kind of service, how are we treating them in such a way that they want to be engaged as partners in their care, how are we designing digital applications with them and not for them, not sort of assuming that we know what's best for them, but really incorporating them into the process. And that's something we do a lot in my office. We are doing user research with veterans all the time. My team is currently working on a modernized patient check-in application that allows veterans to complete some of the like pre-visit questionnaires, updating your address, updating your insurance information, stuff like that. And you've probably done this during the pandemic, and we're trying to bring that to VA. And then being able to check in right from their mobile phones when they get to the VA, and then completing some of the tasks after, like linking to beneficiary travel and other types of things. And so we have been doing a lot of research. We do it remotely. But we are also doing some work now with clinicians, recognizing that the clinician experience is also really critical to making sure that we're delivering great care for our doctors. So we're working on a lot of clinical decision support applications, incorporating clinician feedback to make sure that we're delivering them the data that they need, the right amount, at the right time, in the right place. And I know some of my colleagues kind of alluded to that piece earlier as well. And that's important whether we're doing it remotely, telehealth, a phone call to check in on a patient, or whether we're doing that in person. We're understanding the pain points that a veteran may have when they are trying to check in for their appointment on their smartphone, or whether they are trying to make that appointment online, whether they're trying to complete some forms after the fact. I think we have been leaning really hard into incorporating veteran and clinical feedback just throughout the process. And I hope my audio worked okay. I got some alerts during it.
It came through loud and clear from me. Yeah, no worries there. And Scott, let's hear from you. In terms of, again, the DoD community, what are some best practices in making sure that telehealth is as good as it can be?
Yeah. So, I'd start off and say one word. It's ambiguity. When we specifically talk about telehealth, it's from a DoD perspective, it's not just specifically about the customer experience. And although I completely agree it is, we have to look at, telemonitoring capability. We have to look at teletraining capability. We have to look at telereadiness capabilities. As we move our patients, specifically the warfighter, they move from ship to shore to role 1 to role 2 to role 3 facilities. And the ability to tap into the healthcare resources that we need to be able to take care of these patients isn't as cut and dry as just having 5G technology capabilities. It's not as cut and dry as having an app on a phone. It's the ability to be able to connect and have pipelines to be able to reach back to our clinical assets that we need based on specific situations. So it's advancing that capability using AI and machine learning to be able to move towards a larger telehealth enterprise. Over.
All right, great. Thanks for that, Scott. And I think it's time for our second poll question of the session. Alyssa, if you could please get that ready for everyone. On a scale of 1 to 5, in your opinion, what kind of staying power does telehealth have? And another pretty consistent message here. 85% say it will be part of our new normal. And I think that's probably a great pivot in the conversation here. We hear that a lot these days, new normal. And, in this space, it's certainly not a post-pandemic way of thinking right now, because as so many of you have pointed out, we're still in the pandemic. And but in terms of the years to come here, how do you see telehealth fitting into that new normal? Is this something that we're going to see as part of agency missions for the indefinite future, or help me better understand what that looks like?
Jory, I think one thing that will inform that the answer to that question is you look at how the work from home phenomenon has presented itself to corporate America, and the question is to whether work from home is just a temporary factor, or is it something we're going to have to live? Is it part of the new normal? Whether it'll be complete or maybe a hybrid of some sort. But I think clearly there's no question in anybody out in industry or the corporate world that doesn't appreciate that the work from home phenomenon, with what it taught us about life quality for the employee, the customer experience of the employee in that case, all those variables say that clearly that's going to contribute to it's being a continuing aspect of our lives going forward. So I think every argument you see, you can just translate it over in terms of what you might say about the telehealth experience and whether it's going to be with us, and if so, what will be the challenges associated with it, because I think they translate almost one for one the issues that we're facing.
Okay, well, Scott, just in terms of telehealth and that new normal, how do you see this fitting into it?
Yeah, I mean, I definitely agree. It's definitely going to be the new normal. As we look across the broader enterprise, I would even expand it further to say that a lot of the brick and mortar concepts of healthcare facilities will slowly transition to be more of a digital platform. We're seeing, big industry, Walmart, I know Apple's played in the space, Google's played in the space, Amazon's looking to play in the space. And then additionally, if we look at telehealth and the roughly 80% of the nation that's health record systems, there's really a biopoly when you look at that across the entire United States enterprise, and even really globally. A lot of these EHRs have expanded globally. So I really do believe that it's here to stay, and it's an opportunity for us to have a nationwide health information exchange by collapsing down some of these silos and working together across industry.
All right. And Lauren, in terms of staying power of telehealth at VA, how do you see that future playing out?
I heard early on that there was an estimate of, about we would land after the pandemic at about 30% of type of encounters being a telehealth encounter. And I think what Scott just mentioned, particularly in terms of the other players in the field, I'm not sure I buy that. I'm not sure I buy the 30%. And I think it actually might be something higher. We're seeing now not just that veterans and patients are wanting to get their care in an accessible and easy way, right? And we talked about the work from home. If I'm working from home, it's very easy for me to slot in a 30-minute appointment with my endocrinologist if it's over Zoom, as opposed to having to take X number of hours of my day to go to the doctor and come back. But I think we're seeing kind of a shift in the doctor-patient communication, right? So veterans, patients can contribute to their healthcare now. You see so many people wearing devices, Apple Watches, Fitbits, you name it. You see all kinds of other types of devices like glucometers and oximeters and other types of things that people can just buy on the market. They can get them themselves. They are measuring their own healthcare. They are keeping track of their own healthcare, and they want to contribute that to the conversation that they're having with their doctor. And so I think part of it is going to be figuring out how do we make the best use of that data. So we're not overwhelming clinicians, but we are making maximal use of the fact that our patients are considering their health more than the small windows that they were previously interacting with their providers before, in much more of a 24/7. I'm monitoring my sleep, I'm monitoring my steps, I'm monitoring my food intake, I'm monitoring maybe my blood glucose and other types of things that affect my health outcomes. I think the other thing we're going to need to figure out is, when do we what is the balance between telehealth and in-person? When do we really need that in-person face-to-face connection to make sure that we are, picking up on those cues that you may miss over a telehealth connection that you're not quite getting, but that you can do kind of a lot of routine care, or maybe you're checking blood results, adjust your medication up or down. What can we do telehealth? What is telehealth best suited for? What is in-person best suited for? And how do we come up with a good balance of all of these different things, this patient-generated health data, this in-person critical care, this, the emergent care, hopefully we can, use telehealth to our advantage to reduce the need for emergent care, and then just routine telehealth care as well. I think that's the balance that we're trying to sort of figure out how to strike and recognize that it may be different for each patient.
Okay, and Doug, from the CMS perspective on things, where do you see the future of telework?
Yeah, first of all, I'm just going to agree with everybody. It's hard going forth in this because, a lot of the points that I was thinking about, people have already mentioned. So maybe I'll just kind of add a little bit of color to some of what Lauren was saying, which was what is the right balance and what needs to be in person versus needs to be telehealth. And it's something I see also in just clinical practice on a daily basis. It's okay, this patient is saying that they have abdominal pain. And if I were to actually do an abdominal exam, I could make the determination if that patient needs to go to the emergency room or if I can prescribe them the stool softener and things will be fine. So so those challenges kind of rear their heads in many different ways. And so I think it's something that we're all kind of learning. It's also leading to a lot of ingenuity. It's things that I used to need the patient to come into the clinic for. Maybe I can figure out a way to tell the patient how to measure their pulse and tell me what their pulse is over the phone. And there's a lot of give and take with patients. And I think that this is still a relatively new phenomenon in terms of the rates of telehealth that we're seeing now compared to whatever existed 2.5 years ago. And so as research comes out as well, I think it'll be informative of doing that triage, because that's really what it is. It's triage. It's does a patient need to come into the in-person, or do they need to go to the emergency room? Can I do this over telehealth? It's now adding another layer to that triage, when before it was just okay, they're coming in anyways. Now do I decide if they're going to the emergency department or can I deal with it in the primary care office? So anyways, hopefully that adds a little bit of color to these situations that really happen all the time.
I think Jory, I think Lauren hit it on the head when there's probably not one answer for each type of patient or each type of medicine practice. In the corporate world, we discovered that when we're talking about who needs to be back into the office, actually touching hands, pressing flesh, carbon units against carbon units. And we if you're in an innovation team, sometimes that dynamic interplay between humans actually being in the same room together has a value that maybe our security operations centers folks who work 24/7 and very much focused on their screens, they maybe don't need that in. So I think, Lauren, you hit it on the head. It's going to require some careful consideration, and not one answer is going to be right for each and every group in a corporation or every individual in the telehealth world.
Okay, well, John, to that point, I think that is a good segue to our third and final poll question. Alyssa, if you could get that ready for everyone, please. Have you returned to the office? Yes, no, or we are staying remote? And a bit of a mix. We have 44% saying staying remote, 21% saying yes, they have returned to the office, 36 saying they have not. So a little all over the board here, but to change gears here in this conversation, I think there's been a data element sprinkled throughout all of this in terms of, data needed to make informed decisions for the mission here. And that certainly falls within the wheelhouse of the CDAO. Scott, can you tell us a little bit more about the data challenges and the data opportunities over there?
Yeah, absolutely. Thanks. So underneath the new CDAO, we've brought together several different organizations all underneath one, working for now Mr. Craig Martell as the CDAO. And the common piece that we're looking at, it's really it's two pieces. It's a collection of the data with the association of the labeling of that data and the platform that it sits on. And the other piece is scaling up the digital workforce. It's the training pipelines and the ability to start hosting data literacy or data literacy individuals within the respective COCOMs and the services to support the larger enterprise. Deputy Secretary of Defense sent out a memo back on May 5th, 2021 that specifically talks about creating data advantage. And in there, it talks about the common access to authoritative data sources and to bring in roughly 2,500 different data sources into a single enterprise authoritative data management system for analytical purposes and for visualization purposes to be able to start using data as a strategic asset to make decisions for the whole of DoD. Healthcare is just a small nugget of that information. Again, as healthcare is ubiquitous. We have the ability or the capability of touching a multitude of different areas across the military as we train, equip, and deploy individuals, from logistics to cybersecurity to PHI information to PII information. So again, it's bringing all that together to support the overall enterprise. Over.
Okay, and again, in terms of data challenges here, Lauren, how is the VA staying on top of this wealth of data that it has?
VA certainly has a wealth of data, and I think that is an area that my team is particularly excited about, particularly when you think about there's healthcare data, and then there's just service history data, there's military history data, and there's sort of benefits data. And how can we start to be thinking across those spectrums to deliver veterans better care? So some of you may have heard there's a new bill coming out relatively soon called the PACT Act, and that is going to be around really helping veterans get some of their service connected disabilities a little bit easier. And in that, from the health side, my health portfolio side, we're thinking about like, how do we blend that service history data with the health history data to be able to really give clinicians the information that they need, again, right data, right place, right time, to be able to act on that and give their veterans better care. But also, how do we use that to maybe make it easier for veterans to apply for, learn, and access their benefits? One of the things we're working on, just for the very simple healthcare application, the 1010 EZ, is saying, hey, if we know you're 50% service connected disabled, how can we make it easier for you to get through this form? Are there parts of this form that maybe you don't have to fill out because we already know this information about you? How do we get you sort of how do we take the onus out of having to ask veterans over and over again to tell us about themselves, to tell us data that they know that we know? And so I think a goal that my office has is to never have to ask veteran the same question twice. And that's really the nugget in the sky that we're driving toward.
All right, a lot of great goals there. And Doug, over at CMS, from a transformation perspective on things, how is data transformational to the agency?
Data is really important to really guide evidence-informed decision making, as we've been talking about. A lot of us have been mentioning these various statistics we're using to kind of justify the direction we're going. But I think that we've also really been focusing on is data transparency, because CMS has so much important data for the public and researchers to use, and we're not always, we can't do all the analyses that people need to to really know how healthcare is impacting their lives. And so just by making a lot of this data transparent can be really impactful. And so whether that's working with the CDC on some of the COVID-19 related infection data, or that's some more recent initiatives, we've released data on hospital and skilled nursing facility mergers, acquisitions, changes in ownership, to really inform the public as to when these are happening and the impact that can have on their lives, and researchers can connect that to price data or other kinds of databases. That data transparency is really important. A couple other areas where price transparency we've really been pushing is hospital price transparency. We have new we have regulations basically that hospitals need to put their prices online, and we're kind of working with them in many ways to make sure that is being done appropriately. And we are also looking now more at the social determinants of health. I think all of us have realized throughout the pandemic how important the social determinants of health are. And recently, we proposed for the first time new quality measures that really are measuring whether our hospitals are screening for these social needs. And so as part of the marking of when a patient has a social need, we have these codes called Z codes, which have really been underutilized over time. And so the hope is that as part of this screening process, we'll get more information about how people's social needs are impacting their health needs and vice versa, because that really speaks to this idea of providing whole person care. So that's kind of how we're thinking about things in the data sphere. And there's so much other things I could probably talk about as well there, but just to give a taste.
Okay, well, thanks for giving us a snapshot of where things stand there. And John, I'll give you an opportunity to answer that as well, as far as the data challenges and the opportunities for agencies. Where do you see those? Where do you see those across the federal government?
Well, and perhaps this ties back to the question around the customer and user experience, and in the security realm, we often refer to the friction that security has classically been accused of having introduced into that experience. The friction that's so uncomfortable that at the end of the day, they're just ready to pull their hair out because of their 15-character password that has to be renewed every 30 days or whatever. It just but it also at the same time brought to mind that the idea that even if you succeed in actually creating just a wonderful user experience, and they're just at the end of the session, they say that was fantastic, but then the practitioner has to put a little addendum to that experience. Oh, by the way, all the data and information you shared during this session was stolen away and compromised. How does that last little piece of data impact the overall impression of the user experience, no matter how wonderful it may have been up to that point? Well, it would turn it on its head, of course. And it just makes me think a little bit of what Gil said in his opening keynote, where he made reference to the interface now existing between artificial intelligence and the human. We're seeing a more increase of that interaction together. I'm thinking, well, that's interesting, because in the security space, what we've worked really hard to do is we take advantage of all this data out there, and are now educating our math models in a way that they can predict on their own without human intervention. Part of the efforts to undermine and do away with that friction historically there is to leverage the fact that AI can work in the background without the intervention or participation of a person who lives on the wrong side of the digital divide, or anyone else who's maybe out on a ship and hasn't had time to upload their virus file with some signatures or whatever. The model that they have will sustain them for, according to the latest lab findings, for years, in fact, and still be able to defeat the most recent thing we see in the way of attack. So it leverages that wealth of data that we've heard described as the new oil of this new age. Well, yeah, data does enable us to train our math models in a way that they continue to be as predictive as we've seen in the past. But that, of course, brings with it a lot of responsibilities, a lot of complexities, and requirements when it comes to how we protect that and use that. And then again, we've talked about a lot of other things here too, but the new cybersecurity executive order is going to impose some significant requirements in terms of our understanding of not just the data, but the software that we've used to build our platforms upon which that data is funneled, and understanding just what sort of vulnerabilities may be in that chain or that product that's been produced, and that we poured over into our healthcare systems without a clear understanding at times as to what's actually in there. I'm sorry to wane on a bit there, but that's my 2 cents again.
No worries. And since you did mention a couple of things, AI being one of them, I want to think, out loud a little bit more broadly about what we've seen over the past couple of years is, an acceleration of technology in government to, rise to the occasion of the pandemic and continue to deliver on mission. But in terms of that acceleration of technology, that acceleration of tools being used here, in terms of emerging technology that's coming over the horizon here, I'd love to hear some thoughts there. Scott, I know that's something that is very much on the minds of everyone over at the CDAO. Can you tell us a little bit more about how that might intersect with the health IT space?
Yeah, so let's see, where do I start with this one? Yes, so when we look at emerging technology, whether it's quantum computing capability, whether it's in the space of epigenetics, whether it's in the space of biosurveillance, the augmented reality microscopes, the machine learning capabilities, computer vision, natural language processing. Overall, within the industry, technology is definitely outpacing that of government policy. Which is problematic for us because we're so, black and white as far as what the policy says. So the ability for us to start developing platforms and foundation to be able to start testing and curating this emerging technology to support the better of health, and to be able to share that with other federal agencies and other government agencies is huge. I mean, it's something, that the RDT&E space has been so siloed for so long with the creation of a multitude of infrastructure and platforms. The utility that's came out of it has been substantial in a lot of regards to healthcare, but at the same sense, there's a lot of RDT&E that never makes it into operations. And it's because the gap between RDT&E and the ability to operational and maintain these items it's been huge across the government. So I think that us seeing some changes in both organizational structure, us seeing some changes in policy, and us to start to actually address some of the foundational things is going to allow us to move to a larger testing and evaluation platform to get more things into operational and maintenance for the support of the whole warfighter. Over.
Okay, and Doug, of course, your job is entirely, transformational focused and forward looking. Can you give me a better sense of, what are some of your goals for the agency over the coming years?
Sure, related to emerging technology or just in general? Oh, sorry.
Let's center it within emerging technology.
Got it. Okay, I was curious. It's like we got a lot of goals that I could talk about. Within emerging technology, I wanted to maybe highlight a few things. We're definitely thinking about like what emerging technologies can really play an important role in people's lives, and how do we change our policies and procedures to really encourage both the development of new technology, but also make sure that it's done in an equitable way, which I wanted to introduce into the conversation. There's a lot of research out now that shows that how a lot of these, for example, algorithms can have these biases, and how those biases actually play out. So, for example, there might be like a care coordination or care management service that provider or plan is using an algorithm to really decipher like who gets this service and who doesn't. And when a lot of those algorithms, when they predict things like expected future cost or expected future utilization, what we know is that currently underserved populations they're underserved, so they access care less. And so when you're predicting these things, it's based on the current status quo, and it can create these biases. And so I think it's really important for the industry to hear that when you're thinking about these new algorithms and you're developing new technologies, and what will get a receptive ear also on the back end from government agencies, it's important to take these considerations up at the forefront of the development of the technology, because what we're really trying to do with all of where we're going is really to promote equity with all of our programs and activities. And so I wanted to introduce that concept as well.
I'm glad you did, because I'm seeing some head nods from Lauren in terms of that serving underserved communities aspect of things. Lauren, would you like to build on that a little bit more in terms of the VA perspective?
Yeah, I'm really glad you mentioned that. I think from the health equity side, obviously, we're trying to reach a population that is rural, that is increasingly diverse, that has increasingly different types of physical, mental, other sort of challenges that they're facing. And so we are really trying to keep an eye toward the user, right? Come back to the user. And I think one of the things that I'm always kind of nervous about when we talk about emerging technologies is seeing groups trying to have the technology drive the outcome. So let's pick the technology and then figure out what we can do with it later, versus let's look at the outcomes that we're trying to create for our veteran population and pick the technologies that will help us meet them where they are. So sometimes the technologies that we're using are not brand new, right? I mean, certainly we are exploring AI, we're exploring machine learning, we're exploring all kinds of different opportunities to see how we can, deliver better outcomes, deliver better care for veterans. But sometimes the thing we're using is pretty basic. So as an example, during the pandemic and right when the vaccines were coming out, we have an application that we use to remind veterans about their appointments. And we tweaked it just enough so that veterans can write back to us. And we used it to very proactively reach out to our veterans and say, do you want a vaccine? Do you want a COVID vaccine? And they were able to schedule their COVID vaccine, just basic SMS, whether you had a smartphone or not, you could respond to this. And we were able to get thousands of vaccine appointments booked. And what we heard from veterans when we were doing follow-up research with them was, one, you reached out to me instead of waiting for me to reach out to you. And you did it in a way that I could access. It didn't matter whether I had a smartphone. It didn't matter if I was lived very far out. I could respond to that SMS message. I could get an appointment and get a vaccine really quickly. And so I think that as we're, having these discussions about emerging technologies, we need to certainly know what's out there to know what we can use and how we can deliver better outcomes. But those outcomes are the things that are driving the technology, not the other way around.
Okay, a couple of strong points there. Thank you for that, Lauren. And I see we're getting close to time here. So I'll give everyone an opportunity to give some closing thoughts and some final sentiments. John, I'll give you the first opportunity to do that.
Thank you, Joy, and thank you, panel. I've enjoyed the discussion. I feel like a hedonist, but if I'm not having fun on a panel, I sometimes don't want to participate, but I've enjoyed all your comments. It contributes to that positive feeling I have about the future, notwithstanding the challenges and the sophistication of our adversary. I think we do have tools. There are emerging technologies that just make me as excited as I've been in my 30-year career. I am sometimes dismayed at the inertia that seems to hold some of our partners captive sometimes. I think, why aren't they, when they know there's a solution out there, why aren't they embracing it more quickly? We're still seeing daily headlines of people being taken down by ransomware. I think, wow, when we've got solutions that have got trackers that are just off the charts, why is there this inertia there? And I'm still working on an answer there. Adoption rates and new technology is something I dealt with over at Dell and stuff. There's just a fascinating human phenomena is what impacts and influences the rate of adoption. And indeed, I think technology is out ahead of policy in many instances, and even the insurance industry sometimes lags behind. Though I'm starting to see some positive signs even there, where they'll tweak the premiums you pay if indeed you can demonstrate you have prevention in place, and so your premiums come down as opposed to being stymied in the world of reactive detection. But these are exciting times. I think the prowess that the solutions out there offer to securing things like telehealth is going to make it a viable option that we can advance in a secure, frictionless way so that the user has a positive experience. And when we say positive, that means at the end of the day, one that's secure and that they can have confidence in. Thanks again, panel.
Thanks, John. And Scott, over to you. Any closing thoughts for the audience?
Yeah, I would like to, I'd like to take it kind of echo what Lauren was saying earlier. When we talk about emerging technology, I find it really interesting because that term itself, what a lot of organizations are using, it's actually just getting up to utilization of current technology. And so we use the term emerging technology because it exists. But foundationally, we got to get to the point where we can utilize current technology to be able to address emerging technology. So I'm really excited of where the CDAO is going. And it's the concept of flipping the script of the way that we've looked at requisitions and requirements within the DoD. Historically, you have a problem set that you're trying to solve. You're trying to get access to the data. You determine the technology, the infrastructure you're going to build it on. And the grand plan is to transform the organization. But if we flip that completely around, it's the ability to, let's take an assessment on our organizations and our agencies and see where they're at. Let's see what technology they need, because one of the biggest things that's coming out of our COCOMs and our senior executive leadership and services is the ability of dashboards. Dashboards is not an emerging technology. It's a current technology. It's a capability that we can bring today to allow us to be able to build future requirements to be able to start addressing emerging technology. So again, thank you for the opportunity to speak today. Again, I look forward to working with each and every one of you.
Thanks for that, Scott. Doug, over to you. What are some closing thoughts you'd like to leave with the audience?
Yeah, sure. So this has been a lot of fun. Also, thanks for having me, and it's really great hearing all the thoughts of the co-panelists too. I maybe just a couple thoughts here at the end. I think we talked about a number of different things: telehealth, behavioral health, emerging technologies, user experience, and one of the ways that we're trying to think through all of these issues and more is really how does it improve access to care, and what is the implications for equity, because we have such just a profoundly inequitable healthcare system as like a status quo. And so what can we do to make sure that all of these things are working for folks who might not have access to like computer screens to get audiovisual technology, who might live in areas where their bandwidth is not so great, who might have had like historical come from a community with historical disparities, and might not live in an area where they can get access to food or stable housing, and all of that impacts their healthcare. And like, how do we start to consider the implications of that? And so whether that's folks living in a rural area or like some urban underserved community, I think it like kind of goes across the board. And so I think it's really important as we think through all of these new technologies and as we pave the way forward, like how are these addressing longstanding issues within our healthcare system as we move on.
Thanks for that, Doug. And Lauren, you get the final word here.
Lucky me. Well, I have to say this has been a ton of fun, and I always love discussing kind of these issues with folks like this. And I want to return back to our discussion of customer experience, because that for me is the grounding thing in everything we do, whether it's how we use data, how we respond to a pandemic, this one or any future one, and how we use emerging technologies. I'm thrilled that we have a customer experience executive order, and that our government agencies are really starting to embrace it. I'm more than ever seeing roles: director of human-centered design, user-centered design, human factors, jobs like that within the federal government, which is super exciting. And I'm starting to see the same thing in different healthcare industries: focus on patient experience, focus on bridging the digital divide, on reaching people at the last mile. I'm hopeful that as we start to think about the future, that we really think about that doctor-patient communication. So we're thinking about the patient experience, we're also thinking about the clinical experience. And that is the piece that for me is I think still kind of not as well dealt with in the equation. We certainly want to make sure that we are addressing burnout, that we are addressing sort of the overwhelm of too much data and at the wrong time in the wrong place for doctors to be able to act on it. So I'm really excited about the future. I'm really excited about enabling VA's work to really reach veterans where they are, but also to potentially improve the clinical experience as well.
All right. Well, Lauren, a strong note to end on here. And I want to thank the entire panel for a really engaging conversation. And Alyssa, I'll turn it back over to you.
Great. Thank you so much, Dory and panelists. That was a great discussion. Before everyone leaves us today, I did want to thank our partners again at Pure Storage and BlackBerry for partnering with us. And I also wanted to thank our panelists, moderator, and Keynote today. Before you head out, there is one final polling question. If you would like to be eligible for CPE credits, ATARC will send them right to your email. So let me go ahead and put that up for you. If you would like that, you do have to have answered all 6 polling questions. Other than that, we would love to see you at our next event that will be taking place July 19th. But thank you so much for joining us today, and we hope to see you there. Have a great rest of your day.